Welcome to the recorded version of Understanding Diabetes in Older Adults, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Home Instead Senior Care.
Our presenter today is going to be Dr. Amy Dupree. Dr. Dupree, a gerontological social worker, is an internationally renowned expert on lifestyle issues relating to caregiving, retirement, aging, and family dynamics. Dr. Dupree is president of Essential Conversations, Inc., and Dr. Amy, Inc., a company dedicated to family caregiver wellness. Dr. Dupree holds a PhD and master's in social work, specializing in gerontology, and earned her CSA, a designation for which she also trains others as part of their accreditation. Dr. Amy Dupree is a much sought-after speaker at corporate and professional events on the topics of caregiving, aging, and retirement, and she's also a frequent guest on radio and television. And with that, I would like to turn the floor and the presentation over to Dr. Amy Dupree. Welcome, Amy.
Thanks, Steve. I appreciate it. We've got a very meaty presentation today, so I want to jump right in. And what I want to do is start in the introduction by just getting us all on the same page and talking about some statistics. So this slide's a little statistic heavy, but I think it really illustrates what a huge issue this is and growing, and then we're going to move into talking about, okay, so where do we go from here? So as you probably know, there are three types of diabetes. So we've got type 1 diabetes, and that develops if the body can't produce any insulin. We usually see that in people before the age of 40, and especially in childhood. Now, of the types of diabetes, it's the less common of type 1 and type 2. We can't prevent it, and it's not known exactly why it develops, and obviously there are treatments for it, but that's the one, again, that's less common. The more common one is type 2 diabetes. And that develops when the body can still make some insulin, but not enough, or when the insulin that the body does produce doesn't work properly. That's known as being insulin resistant. Type 2 diabetes actually accounts for 90 to 95% of all diabetes. So obviously that's the one we're going to focus on today. The third type of diabetes that we're really not going to talk much about at all is gestational diabetes. And as you know, that occurs in pregnancy, and then it goes away. So according to the Centers for Disease Control, in a report that was just issued late last fall, an estimated 18.8 million people in the United States had diagnosed diabetes in 2010, and another 7 million had undiagnosed diabetes. The thing that's really shocking when you listen to these stats is that the report authors state that since 1995, so that's a 15-year span, 1995 to 2010, the prevalence of diagnosed diabetes in the U.S. has risen sharply among all age groups, both sexes, and all racial and ethnic groups. Now, those figures don't include women who had gestational diabetes, and they don't include people who have been told they have either prediabetes or borderline diabetes. So this is full-fledged diabetes. So in that time period, again, from 1995 to 2010, the age-adjusted prevalence of diagnosed diabetes in the U.S., among U.S. adults, increased everywhere, all over the country, in all geographic areas, with a median prevalence for all states, Washington, D.C., and Puerto Rico, going up from 4.5% to 8.2%. So again, that's almost, if you look at that, almost doubling when you look at those figures. And when you look at where the prevalence is the greatest in the U.S., it's among states in the South at about 9.8% versus states in the Midwest at 7.5%, and then Northeast and West are right behind that at 7.3%. So again, if you want to look at what states have the highest prevalence with greater than 10%, it's Alabama, Mississippi. It's also Puerto Rico, South Carolina, Tennessee, Texas, and West Virginia. And the states that are doing the best with 6% to 6.9% include Alaska, Colorado, Connecticut, Iowa, Minnesota, Montana, North Dakota, Oregon, South Dakota, Wisconsin, Vermont, and Wyoming. And I read those just in case you're in one of the states, either good or bad. You kind of have a sense of how your state is doing all this. Okay, let's take a look at the next part of the introduction and talk about what's causing the increase in numbers. So the increase, according to research, is likely the result of several different things. first of all, our ability to treat and control diabetes is improving. That's a good thing. So what that means is that people are surviving longer, and so that also means there are more people out there with diabetes. So some of the increase is based on something good. The CDC reports that mortality among U.S. adults with diabetes declined substantially between 1997 and 2006, and at a faster rate than among adults without diabetes. So it says that we're treating diabetes better, and that's a good thing. Now, a second thing that has led to the increase has been a change in the diagnostic criteria. So the American Diabetes Association lowered the threshold in 1997, and so obviously that's made a difference too. The third thing that made a difference is we're slowly getting better at detecting undiagnosed diabetes. So all those things are actually quite positive. The fourth thing is kind of neutral. The population's aging, and it's also changing. We're living longer. We have more minority population living longer who tend to be at greater risk for diabetes. But here's the real kicker. The biggest challenge and the biggest driver in those increases is our increased obesity and sedentary lifestyle. So although there are these other reasons we can point to, when it really comes down to it, the truth is that we know that it's the obesity and lifestyle that are really, really getting in our way. Okay, now let's talk about older adults. Older adults are more likely to have diabetes than younger adults. And that probably doesn't surprise you because we know this is one of those things that tends to have an age correlation. So if you look at the 2005-2006 National Health and Nutritional Examination Survey, and this looks at community-dwelling adults, the prevalence of diabetes increased with age, and it tends to peak at about 60 to 74 years. So, again, age-related. From 1995 to 2004, the overall prevalence of type 2 diabetes in nursing home residents now, compared to the community-dwelling residents, increased from 16 to 23%. So, wow, big increase. Now, at the same time, the reason we're focusing in on older adults is because they experience diabetes differently. And there are things that we need to be more mindful of, both when treating older adults with diabetes, but also just when caring for them. And, of course, we're concerned about that because of family members and how it impacts them. Okay, so let's take a look, after all that introduction, to what we're going to talk about specifically for the rest of our time together today. So in today's webinar, what I'd like to do is focus on the needs of the older adult who has diabetes. I'm also going to review some more general information on diabetes and its impact on health. We'll talk about things like how to prevent diabetes, the warning signs, the symptoms, and ways to manage the disease. And I'll also give you a list of resources for further information. Now, as I talk about the particular risks and needs of older people with diabetes, I want you to know that I'm going to draw on recent research by Drs. David McCullough, who's the clinical professor of medicine at the University of Washington, and Amena Munshi of the Joslin Geriatric Diabetes Clinic and an assistant professor of medicine at the Harvard Medical School. I really found their research to be particularly helpful, and I want to share it with you today because I think it's really enlightening. Okay, so let's take a look at some of their research and talk about diabetes in older adults. So according to Drs. McCullough and Munshi, older adults with diabetes are at a risk of developing a similar range of the macrovascular and microvascular complications as younger adults with diabetes. Looks about the same. However, their risk for cardiovascular disease is much higher, and obviously that's a big concern. Older adults with diabetes suffer excess morbidity and mortality compared to people who are the same age without diabetes. So, this is a serious issue both from a personal standpoint, and it's also a serious issue when you consider the medical system and the care that we need to provide. Because you compare these two populations, older adults with diabetes and without, and they look quite different in their morbidity and their mortality. In addition, the ones who have diabetes are at a higher risk for polypharmacy, meaning multiple drugs, functional disabilities, and common geriatric problems, things like cognitive impairment, depression, urinary incontinence, falls, persistent pain, all are greater in older adults with diabetes. So this is a serious issue that as professionals, we need to really help both our clients who have diabetes and their family members figure out how to prevent, treat, and provide better care for them. We need to be aware of these differences and be able to communicate them so we can both talk to, again, the older adult and to their caregiving family member. Okay, so when we talk about older adults with diabetes, they're not all the same, of course. And Steve, you can flip to the next slide if you want here. We're all individuals, so we can't just lump everybody together. Older adults can range from those who are, very fit and active and healthy to those who are really frail and have a number of chronic conditions and functional disabilities. So again, according to the doctors McCullough and Munchie, the overall goals of diabetes management in older adults are similar to those in younger adults. So that includes management of hypoglycemia, which is high blood sugar, and the risk factors. But in frail elderly patients, there's another issue. It's the avoidance of low blood sugar, low blood pressure, and drug interactions that really are of a much greater concern than they are in younger patients with diabetes. So, too, is managing other coexisting medical conditions, because this really does have an important effect on how well older patients can perform self-management. So what we're saying here is, if you look at high blood sugar, it's about the same in how you manage it. You start talking about low blood sugar, and this is a real risk for our older, frail patients. We're going to talk more about this. For example, when we talk about low blood sugar, that can impair cognition and functioning. In older patients, it also causes more dizziness, weakness, delirium, confusion. Now, I'm sure you can see the problem here because all of those things make falls more likely to happen. And we all know how easy it is for one bad fall to make a significant life change that's detrimental to the older adult. It means somebody can go from being independent, living alone, to needing hospitalization, perhaps for a broken hip, and then having to move into a nursing home. So this becomes a serious issue for us. Accordingly, target blood sugar levels in older adults need to take into consideration life expectancy and overall health. So what we're saying here is it's actually better for the patient to have a higher level of blood sugar and a better quality of life and less risk of falling than it is to have those lower levels but have the higher risk of falls and lower quality of life. All of those things have to be taken into consideration. So it isn't simply a matter of looking at blood sugar levels. It's taking a look at the whole package. Okay, now let's talk about some specific concerns for older patients around two conditions especially. So in addition to managing the blood sugar levels, there are a few areas that need to be monitored: the eyes, the kidneys, and the feet of elderly people with diabetes. That's because retinopathy, which is damage to the blood vessels at the back of the eye, nephropathy, which is the kidney disease caused by damage to the small blood vessels in the kidneys, and foot problems are all very important complications for elderly patients. And the longer a patient has diabetes, the more they're at risk of retinopathy. Regular eye exams are really important for elderly diabetic patients because poor vision has a lot of implications. It can lead to things like social isolation, increased risk of accidents, impaired ability to measure their blood glucose levels and draw insulin doses. Doctors McCullough and Munchie recommend a complete ophthalmological exam be performed by a qualified ophthalmologist or an optometrist at the time of diagnosis and at least every year thereafter. So a lot more monitoring than we might think of for someone who doesn't have these problems. Because the purpose is to screen not only for the diabetic retinopathy, but also for cataracts and glaucoma, which also are more common in people with diabetes. Cataracts are over twice as common in people over age 65 who have diabetes compared with people over 65 who don't have diabetes. So you can see that the thing with diabetes is that it impacts so many areas of the body, and that's really the biggest concern. Now, if you talk about nephropathy, because there's effective therapy for this, it's now recommended that all patients be screened annually for the kidney issues as well. Okay, let's move on and talk about the foot problems that tend to develop. Foot problems in older adults can be a huge issue. First of all, just older adults in general, we know, are at risk of more foot problems than younger people. Studies actually estimate that the prevalence of diabetic neuropathy in patients with type 2 diabetes is 32% overall and more than 50% in patients over 60 years. And this is a real concern because diabetic neuropathy causes a lot of pain and a lot of issues. So in addition to the increasing prevalence of neuropathy with age, more than 30% of older diabetic patients can't see their feet or reach their feet. And that means they can't do their foot inspections. Now, I know all of us who've worked with older adults know that becomes a problem for many, many older adults. I often tell about my father who, in the last years of his life, couldn't reach his feet and the problems that it causes just for people to put on socks and maintain their grooming of their feet. But when you add in diabetes to this issue, now you've got a bigger problem because you can't do your own foot inspection. Therefore, again, Drs. McCullough and Munchie recommend that the elderly diabetic patients have their feet examined at every doctor's visit. And this exam should include an assessment of the patient's ability to see and reach their feet, and also inquiring about other family members or friends who could be trained to do routine foot inspections. They might even consider visits to a podiatrist on a regular basis. That might be important. A detailed neurological exam and assessment is very important on an annual basis for peripheral artery disease, because that's another issue here with the diabetic neuropathy. So all very, very important issues. Okay, now let's talk about another issue that we see that's a specific concern for older patients, and that's cardiovascular disease. I mentioned earlier that older people with diabetes have a much higher risk of cardiovascular disease than do younger people. In the Framingham Heart Study, which I'm sure many, many of you are familiar with, the presence of diabetes doubled the age-adjusted risk for cardiovascular disease in men and tripled it in women. Both diabetes and age are major risk factors for heart disease. So in a way, it's not really surprising that heart disease is the leading cause of death in elderly people with diabetes. But I think you can see this adds to the problem. It's not just the issues that we typically see around heart disease. Now we have this increased risk with diabetes. So doctors, therefore, recommend focusing risk reduction efforts in the following areas that you see on your screen right now. I'm only going to touch on a couple of these, but if you have questions at the end about any of these, we can talk about them more. So smoking cessation. People with diabetes who smoke seem to have an increased risk from smoking than smokers who don't have diabetes. So again, another issue that seems to be raised in people with diabetes. So it's especially important to work with them to stop smoking. Another issue that we have is high blood pressure, and that's very common in the elderly. In the U.S., high blood pressure was observed in 67% of adults age 60 and older who were participants in the National Health and Nutritional Survey. So this is a big issue, again, for people with diabetes. Now, you see another term there that you may not know, the dyslipidemia, and that's abnormal blood cholesterol and blood fat levels. So that's what that refers to. And that's, again, greater risk for people who are older. Exercise. We know, I think almost every time we do any of these webinars, exercise comes up as one of the major issues as a way to prevent problems or to reduce the problem. And it's true, again, with diabetes. It's beneficial to help maintain physical function, to reduce the cardiac risk. But with diabetes specifically, it also improves insulin sensitivity. In older adults, exercise also improves body composition. And that's important with diabetes because we know that there is a tendency as we age to move to more fat and less muscle. And by doing that, it increases the issue around insulin sensitivity. So by exercising, we improve our ability to manage insulin. Very, very key. It also helps, obviously, deal with arthritic pain, reduce falls and depression, increase strength and balance, increases quality of life. And it does also improve survival. Studies of frail elderly people have shown that weight training should be included in addition to aerobic exercise. And again, we said that last month, and again, that comes up over and over again, that it's not just about cardiovascular, it's also about doing the strength training. So important on cardiovascular. Let's now move and look at cognitive impairment. According to Drs. Marie Florence Shadlin and Eric Larson, several prospective, large, population-based cohort studies have found that diabetes is associated with an increased risk of cognitive decline and dementia. And I'm sure if you're working in the field around dementia, you've heard this correlation more and more in the last few years, that having diabetes puts you at greater risk for dementia. So there was a systematic review of these studies, and it found that diabetes is associated with a 50 to 100% increase in risk for Alzheimer's disease and of just dementia overall, and 100 to 150% increased risk of vascular dementia, which, again, is pretty astounding in the levels that we're talking about. Many older patients with dementia remain undiagnosed, particularly in the early stages, and elderly patients with diabetes and cognitive dysfunction may have problems, as you might guess, performing some of the things they need to do to take care of themselves. So there's a lot of self-management, and there's treatment regimens that have to be followed. And if they, in addition to having the diabetes, also have dementia, this makes following these treatment regimens very tough. According, again, to McCullough and Munchie, cognitive function should be assessed in elderly diabetic patients when there is non-adherence with therapy or frequent episodes of hypoglycemia and deterioration of glycemic control without any obvious explanation. So again, this is really key, that there is this need to not just be assessing for the diabetes, but making sure that our clients understand and their family members understand there are all these other issues that go along with diabetes that need to be checked on a regular basis. Let's talk about another one, which is depression. Studies show that depression occurs at a higher rate in older patients with diabetes compared to older patients who don't have diabetes. So again, as with older people in general, depression is often undiagnosed, and it remains untreated in this high-risk population. So this is really key. Just being older and having depression means you may not get the assessment you need. Now add in diabetes, there's a whole other issue here. So depression has been associated with poor glycemic control and with higher rates of coronary heart disease in diabetic patients. So early identification with a short screening tool, such as the geriatric depression scale, for example, and with treatment may help achieve better glycemic control. So that's an interesting correlation, that treating the depression actually helps people better control their glycemic levels. Okay, now let's talk about the polypharmacy issue. And I don't think this will surprise anybody that we have this issue with people with diabetes, that they're taking more drugs. So the use of multiple drugs obviously is common just in older adults in general. But according to the Georgetown University Center on an Aging Society, adults with diabetes fill about 4 times as many prescriptions and spend about 4 times as much on prescription drugs as the general population. And if you think about that, that's astounding. So another huge issue. And now when you talk about polypharmacy, you have to add in the issue of side effects. And the side effects of different medications can cause a whole set of problems all on its own. And that, again, can impede people's ability to manage their diabetes. So it's very, very important when we talk about older adults with diabetes that their medication lists are kept up to date and that they're reviewed on a regular basis as part of their regular doctor's visits. Okay, another issue we mentioned is falls. Let's look at that one. According to the CDC, each year, 1 in 3 adults age 65 and older falls. 1 in 3, pretty high. Falls obviously can cause everything from minor to moderate to severe injuries, and the severe are things such as hip fractures and head injuries, and they also actually increase the risk of early death. And again, if you've been working in the field for a while, you've probably witnessed this and worked with people who did die because they had had a fall. There were complications related to the fall, and it led to death. Now, I mentioned falls earlier when talking about the need to control blood sugar levels. And if you think about that, there are several factors that can cause a fall. And those include things like low blood sugar, nerve damage to the feet causing the numbness or pain, that's the neuropathy, muscle weakness, loss of vision, we talked about the retinopathy, or the dizziness that can be caused by drug interactions. So again, according to McCullough and Munchie, while good glycemic control can slow the progression of diabetes complications, and that helps decrease the risk of falls, Hypoglycemia that occurs as a result of intensive glycemic control may actually increase the falls in older adults. And this is what we talked about before, that there's a balance here between getting the blood sugar levels right and making sure that they're not too low so that we're causing these other complications. So they recommend the use of what they call less rigorous glycemic goals in the elderly as a means to prevent falls. And I think that that's an interesting conversation that we can be having with clients and family members to make sure that they're being treated by doctors who really understand the difference of diabetes in older adults versus diabetes in the younger population and the difference in the treatment regimen for those. Okay, let's take a look now at how do we prevent all of this. So what do we do to prevent diabetes? And this is good for all of us, not just older adults. So as I started by saying to you, one of the biggest drivers that we see of diabetes is being overweight. And if you look at that, excess weight also increases the risk of heart disease and stroke and high blood pressure. It increases our bad cholesterol and high blood glucose. We really need to look at this issue. I also mentioned that smoking is another risk factor. Smoking hurts, we know, the lungs and heart. It also lowers the amount of oxygen that gets to a body's organs, and it raises bad cholesterol, and it raises blood pressure. So a lot of issues besides just the heart and lungs. There are some risk factors for diabetes that we can't change: age, race, gender, family history. However, we know that people could really prevent or delay the onset of type 2 diabetes through a healthy lifestyle. And you see on your screen the healthy lifestyle. And I am sure there is not one thing on this screen that looks new or shocking to any of us. It really is eating healthy as one of the most important things that can be done to lower our risk. So that means more fruits and vegetables, more whole grains, leaner meats, smaller portions, drinking less soda, eating fewer sweets, chips, other snack foods. All of those things can have a very positive impact in preventing diabetes. The other part of this is doing some form of physical activity at least 150 minutes a week. So this means something like walking for 30 minutes 5 times a week. That's a key way to help prevent type 2 diabetes. The American Diabetes Association suggests 4 components in a physical activity routine. So this is their recommendation. The first one is walking, using the stairs, just generally moving around throughout the day. Next is to add some aerobic exercise, such as brisk walking or swimming or dancing. The third is strength training, lifting weights, light weights. And fourth is doing flexibility exercises, such as stretching. So moving around more, getting some cardiovascular exercise, doing strength training, and doing flexibility. That's the key in exercise. Diabetes clearly does not have to be a given. By incorporating these simple measures, it really is possible to live a healthier life. We should also be aware of the signs and symptoms of diabetes so you know when it's necessary for someone to seek medical intervention. So let's take a look at some of that. Actually, I'm going to do one more slide on this before we go to that. So studies have shown that these lifestyle changes that we're talking to can all be used to improve glycemic control. Medical nutrition therapy, and that's a process in which a person's diet is tailored to his medical history, their lifestyle, their personal factors, has also been shown to bring really great results. So there was a randomized trial of medical nutrition intervention of adults who are older than 65, and patients who did that in the intervention group had significantly greater improvements in fasting plasma glucose than control patients. So that means that really getting people to look at their diet from a professional standpoint and make changes make a big difference. Interestingly, the oldest age group in the diabetes prevention program had the greatest improvement in glycemia over time compared to the younger age groups. And by the way, when they say the oldest age group, that's just greater than 60. It's not, they're not pulling out 80-year-olds in that. So 60 and over actually did better. So what that tells us is that our older clients can respond really well to these lifestyle programs. And Drs. McCullough and Munchie really say that elderly patients with diabetes should receive a medical nutrition evaluation based on these studies. Okay, now let's take a look at the signs and symptoms. And again, my guess is that you probably know some of these because we've been educated more and more around diabetes to recognize some of this. So how can we tell if someone's at risk of diabetes? Well, it often goes undiagnosed because many of the symptoms seem so harmless. And the truth is, in many cases, people with type 2 diabetes really don't display any symptoms at all. But there are several symptoms that are in common with type 1 and type 2 diabetes. The first one is frequent urination. So if you notice someone's running to the restroom more than usual and it's accompanied by unusual thirst, those are two of the most common symptoms of diabetes. Another is unusual weight loss, and that's something that many of us don't think about. And I actually recently had a friend who was diagnosed with type 2 diabetes, and that was his number one symptom, was he noticed that he had weight loss that he couldn't explain, and he had a very significant loss of energy. And that made him go in to get checked, and he did have type 2 diabetes. He's now on medication and very quickly started to go back to his baseline. But if you see somebody losing weight without trying, that's an issue. It's more noticeable, actually, the unusual weight loss with type 1 diabetes, but it's still an issue in type 2. Glucose-starved cells may also signal the body for more food, thus increasing the appetite. So that means extreme hunger can be a sign of diabetes. And then, as I mentioned, extreme fatigue, and another one to put on the list are irritability. Now, type 2 diabetes has some other less common symptoms, too. Things like frequent infections, blurred visions, cuts and bruises that don't heal very quickly, recurring skin, gum, bladder infections. Those can all be related to type 2 diabetes. Tingling and numbness in the hands or feet or neuropathy is another symptom. The thing with type 2 diabetes is it has a gradual onset. So people are often not aware that they have it, and nerve damage can be happening for years before there's a diagnosis. According to the American Diabetes Association, testing high-risk people even without symptoms and the early detection of diabetes symptoms and treatment can decrease the chance of developing all those complications that we talked about. So people need to get tested, and they need to have early intervention. There are a few tests that can be performed to determine whether somebody has diabetes. Let's take a look at those and see what they are. So if someone's experiencing symptoms of diabetes or has some of the risk factors, then their doctor may choose to test and monitor them for diabetes or prediabetes, which is the precursor to type 2 diabetes. The first and most common test is a fasting blood sugar test. For this, people have to fast overnight, usually at least 8 hours, and then have blood drawn that's tested in a lab. This test can also be done in the doctor's office using a glucose meter. Another option that's not used as frequently is called the glucose tolerance test. It also requires fasting overnight, and then the next morning the doctors take a baseline plasma glucose test before giving the patient a dose of glucose, usually in the form of some sweet-tasting drink. Blood samples are then taken over a period of hours to measure the blood's glucose levels. So that's two of them. The third, and the simplest diagnostic test, is the hemoglobin A1C, or just called the A1C test. This blood test requires no fasting. Now, when a doctor confirms that a patient has diabetes, we know it's very normal for them to feel many different emotions and experience considerable stress. So one of the things we want to look at is how to manage dealing with a diagnosis of diabetes. So according to the American Diabetes Association, how a patient perceives this diagnosis really greatly affects how successfully they're going to manage it. So the American Diabetes Association recommends 4 steps. First is to learn to laugh. That seems like a funny recommendation in some ways, but as you know, positive thoughts do have positive physical effects, and thoughts and feelings have an enormous impact on a person's body. So that's their number one recommendation, is to recognize the benefit of laughter. And then the second is related, which is to focus on positive. We know that having diabetes stinks, but we also know it can be managed. And these are things we can really encourage our clients to think about, because learning to laugh and focusing on positives are things everybody can do. Third, patients should remember they are more than the diabetes. It's just a small part of their entire complex being. So having patients recognize their self-worth and recognize that this doesn't define them is really important. And then the fourth is to have the treatment plan. And part of the treatment plan starts with being mentally prepared, because what we mean here is people who don't follow their treatment plans, if they don't get into the mindset about how important it is and that they can do it and that they will do it. So, again, American Diabetes Association recommends these 4 steps, and they're steps that we can easily recommend to our clients and to their family members. So now let's talk about another aspect of this, about managing diabetes. So in his article, which is called Diabetes Technology During the Past 30 Years, a lot of changes and mostly for the better, Dr. Larry Deeb, who's a pediatric endocrinologist, and he's the medical director of the Diabetes Center at Tallahassee Memorial Healthcare, he documents the enormous changes that we've seen in the treatment of diabetes in the past 30 years. While there's always more that we're looking forward to, I think we really can feel a sense of hope and optimism. The technology and the tools are improving, and so much more is within our control. So partly within our control, people with diabetes have the same nutritional needs as everyone else. So eating well-balanced meals should be the main goal. And then the exercise, also an important component. This means getting active. And it also means that if we do this, and we encourage people to do this, we're going to not only stave off diabetes, but for people who have it, we're likely to stave off the complications such as heart disease and high blood pressure. Checking blood glucose levels every day and logging the results can really help determine if the diabetes management plan is working. And I think, again, encouraging people to stick to that is important. Doctors can also do an A1C blood test at least twice a year, which, again, looks at those glucose levels over a 2 to 3 month period. While a healthy diet and exercise alone really can help some people with type 2 manage their diabetes, other people obviously are going to need medication to help keep blood glucose levels down. So we're talking about oral medications that are often used now in those that are recently diagnosed. So it doesn't necessarily mean insulin shots. Now, insulin is required for people with type 1 and sometimes necessary for people with the type 2. Most people take their insulin around meals, but some type 2s only need 1 injection a day. With the help of a healthcare team, people can really establish a good insulin routine that will keep their blood glucose levels under control. Controlling blood glucose and high blood pressure help prevent problems. Sometimes, though, kidneys get damaged so badly that they no longer work, even with this good management. When kidneys fail, one option is a kidney transplant. For those with type 1 diabetes, there are also pancreas transplants. Those are obviously very, very dramatic measures, and the goal is to help people prevent as much as possible getting the complications if they already have the diabetes. I think the really good news is that with a proper management plan, for the most part, in most people, diabetes really, really can be controlled. Okay, let's take a look now at some of the resources. No surprise, the first place we're going to send you is the American Diabetes Association. So the Home Instead Senior Care Network actually is working together with the American Diabetes Association to help diabetic seniors and their caregivers learn how to manage these issues and live life to the fullest. So there is a video online at thecaregiverstress.com that was done in conjunction with the Diabetes Association that's really worth taking a look at. The American Diabetes Association notes that it's the only organization in the United States committed to helping children and adults with all type of diabetes as well as those who are at risk. So they work both on the prevention side and for those who have it. They have thousands of volunteers and staff across the country, and the American Diabetes Association really dedicates itself to improving the lives of all those who are affected by diabetes, including the caregivers, so that hopefully one day there'll be a cure. And their website is worth getting on if you've never been on it. There's great information on there, and there's things that you should be familiar with that you can share with your clients and their families. And again, the Home Instead website and the Caregiver Stress website have many helpful articles and videos about dealing with diabetes. So great sources to go and look for other information. Okay, let's talk about where do we go from here. When you're talking to your clients, the three things you can tell them right away that they can do are obviously eat a healthy diet with fresh fruits and vegetables, keep active with regular exercise, and see the doctor for early treatment when there's warning signs. And I think if we could just help people with that, and then on the side of if they already have diabetes, making sure that they get proper screenings on a regular basis, if that as older adults, that they're being treated by doctors who understand the difference between diabetes in older adults versus younger adults, and making sure that they're following the plan as best as possible are really key. And, of course, we have the added complication with some people of the dementia along with us. Okay, I'm going to pause now. I'm going to turn this back to Steve, and we're going to open up the phone lines for questions.
All right. Great presentation, Dr. Amy. Thanks a lot.
Thank you.
And as Dr. Amy just mentioned, it is time for the Q&A portion of today's web seminar. We also want to welcome to the call Mary Alexander from Home Instead Senior Care, who is joining us for the Q&A portion. Welcome, Mary.
Thank you, Steve, and hello, Amy.
Hi, Mary.
Okay. Amy, earlier you were talking about some of the diagnostic criteria and how that has changed. The question is, what diagnostic criteria changed in 1997?
What diagnostic? I have to go back and look at that. Hold on one second. Steve, why don't you take another question, and I'll go back and look at that, okay?
Sure. You were talking earlier also about foot problems with older adults who have diabetes. Now, what exactly are you looking for, problematically speaking, with the feet?
Well, and remember, I'm not a medical doctor, but I will tell you that one of the things that people have to check for foot problems are sores on the feet. That's one of the issues. Sores that don't heal are a big issue. So that's one issue. And then problems also with nerve endings and those sort of things. Neuropathy is a problem. People often have a lot of tingling and sensitivity in their feet, and any of those things should be checked out immediately by a doctor.
You know, and I'm going to add to that too. My dad actually is a diabetic. He's an insulin-dependent diabetic, and the other challenges that we have with his feet, other than the sores and the ulcers, his nail trimming is a challenge, and we actually take him to a podometrist just simply to have that task done, because that has to be done exactly right, or that can cause a great deal of problem. And just to give you a sense, my dad lives in a different state. We missed an ulcer on his foot, and the small ulcer that started, it ended up, that small ulcer that we caught very, very early on was over a $30,000 expense because of the complexity of feet issues. So it is very important, it's very, very important that anyone with diabetes checks their feet regularly.
Absolutely. And the nail issue, Mary, I just want to add to that, because that issue is such an issue for so many older adults. And I think, again, so many of the things we're talking about with diabetes are things that we sometimes see in other older adults who don't have diabetes. They're just exacerbated in this population, and that's one of them that's exacerbated. Okay, Steve, I want to go back to that first question, the changes in the diagnostic criteria.
Yes.
Is that the American Diabetes Association lowered the threshold in 1997 to greater than 7.0 mmol, and from the then current World Health Organization criteria of greater than 11. So it dropped quite a bit. And that's a 2-hour glucose concentration that they're looking at. So that criteria dropped. And if somebody's interested in looking that up, there is information on that, I believe, on the American Diabetes Association website. So what they did was say what the criteria was for World Health Organization. They wanted to lower it. And I think we see that not just in diabetes. You see that in some other things happening. You know, blood pressure, what we used to consider borderline and normal has dropped a bit. And same thing here. So that's what dropped in 1997.
Okay.
And I can send that reference if somebody would like that.
Okay, good to know, good to know. Okay, we were talking earlier about risk factors. Question is, are some people genetically predisposed to have diabetes despite a healthy lifestyle? Can you talk about how genetics plays in as a risk factor?
Well, it's definitely a risk factor, and the only thing I can say to you is, again, not a medical doctor, but we know that is one of the ones that you can't change of the risk factors when we list them out. You know, we talk about age and gender and ethnicity. Another one is family history. So I beyond that, I can't speak to that more specifically. Mary, do you want to say anything more about that?
Yeah, again, I'm not a medical doctor either, but there is some connection with genetics. Obviously there are 3 members of my family that have it, but also your lifestyle plays a key role as well. But there is a great section on the American Diabetes website that does talk about that. So I would definitely suggest you look at that section.
Okay, earlier we're talking about exercise as well. The question is, do experts say that the 30 minutes of recommended exercise a day, can that be broken into smaller time bits, or is it like 30 solid?
Again, I don't want to speak to this from a medical perspective as the authority, but my understanding of this in other things that I'm reading a lot lately is that it can be broken up. It's just making sure you get that full amount, the 150 over the course of the week, because it could be, broken up different ways too. But it's the 150 minutes that seems to be the minimum threshold.
Yeah, and I would add to that. I think your doctor plays a key role in helping you create your plan of care specifically for this instance. So let me give you an example. My father, which I'm closest to, so I will use him as my example. Before he turned 70, they wanted a specific exercise program for a specific amount of time. As he turned 70 and things started to change, they broke his exercise routine into 2 times a day, so 2 smaller increments. He actually did 2 20-minute increments, one in the morning, one in the evening. And after he turned 75, they broke it up into 3 smaller increments, one morning, one afternoon, one evening. So again, I think it all has to do with your doctor's recommendation and what you're dealing with, because my guess is you could probably be dealing with other illnesses or issues, and all that is taken into account.
Okay, the next question is about medications. Did I hear you say that some medications are oral and insulin are injections? Are there other meds besides insulin, or are the oral meds insulin too?
Again, I'm not comfortable speaking to that. My understanding is that there are a couple of different options, but I'm not an expert on that.
Okay. Do you have any insight on where we can find, or any resources on where we can find diabetic meal planning menus?
Mary, do you want to speak to that?
Absolutely. There's a couple of great sites. First of all, I'd recommend you first look at the American Diabetes Association site. They have great information on nutrition and meal prep. But you can also do a Google search on nutritious meals for people with diabetes. There's also some great cookbooks out there. Again, I tell you that I find the majority of my information on the diabetes website. Yeah. Also, I would suggest you look for a chapter of the American Diabetes Association in your area. A lot of times they'll have cooking classes, they'll have support groups, they'll have a lot of different events. And then normally your local hospitals have some events too. So those would be the key areas that I would look at.
Okay, next question. I have a relative who is obese and having foot problems and knee problems as well. She's had problems with movement due to the knee pain. Her doctor has been telling her to follow a diabetic diet and try to lose some weight. She tries to eat better, but she's not losing the weight. Is there some outside information that can be done? She says that she has problem exercising because of her knee pain. What can we do to address this situation?
We at Home Instead deal with that quite a bit. I'm going to tell you the best exercise if she has any kind of a leg or knee problem is consider the pool. It takes the strain off of the knees, but you still get a rigorous exercise from that. And you'll see that, again, if you check with your local chapter of the American Diabetes Association in your market, sometimes they have classes specifically for diabetics. In a pool. So again, that would be one of the areas I would absolutely recommend that they look at based on doctor's approval.
The other thing I might add to that is just consider maybe a nutritional assessment too. That I mentioned the fact that people who have some nutritional counseling have better outcomes, and I don't know if saying follow a diabetic diet is different from actually having somebody evaluate your diet. So she may need some help with that too.
Okay. The next question, how about a vegetarian diet for a person with diabetes? Would that be helpful or not?
Well, Mary, do you want to speak to that? Go ahead.
Well, I think, both of us probably say the same thing. I think anytime you can eat a healthy lifestyle based on what your doctor suggests to you is important. And I'm not sure what research is there about a vegetarian lifestyle, Amy?
I don't know the research on it, but what I would say is that the part that is clear is all the recommendations are always more fruits and more vegetables, and if you're eating meat, the lean meat. So it would be, more grains. I think the thing to do would be, I'm guessing the American Diabetes Association probably has some information on that on their website. I'm not sure of that, but it would make sense to me.
Okay, a little bit earlier you were talking about symptoms. Can you please define or quantify the term frequent urination as it relates to the symptoms?
The research just called it frequent urination. It doesn't say, going this amount, so I can't actually define that for you. And I know some of it is for people, it's a shift in some people have a tendency to urinate more frequently because they drink a lot more fluids and they just have that sort of habitual pattern of urination. So some of it is a shift in that. And if somebody is concerned about the frequency, they definitely should talk to their doctor about that. And, getting the diabetes test is so simple. Probably most of us who have annual exams are getting tested for diabetes on a regular basis. And so I think that would be the key, is to make sure you're getting tested.
Okay, next question. When I'm working with my clients, how can I explain to them or speak to them and make it clear that they will always have diabetes without making them feel doomed or hopeless?
That's a great question. And Steve, can I just go back and say I did check. The American Diabetes Association website has meal planning for vegetarian diets on it.
Okay, good to know.
Okay, so if people want to get on that website, diabetes.org, there's actually a place for meal planning for vegetarian diets.
Okay.
Okay. Sorry. Now this question about how do you help people with the emotional side of this?
Yes, exactly.
Mary, do you want to start this one?
You know what? I'm going to tell you that there is a huge piece of the emotional side, and another example I'll use is when my sister was diagnosed, she was in her late 40s, and there was a moment where she thought her life had to significantly change, that she was going to have limitations, and so from the emotional side of that diagnosis, I think the doctor clearly told her, this is just something you're going to deal with. This isn't necessarily going to change your activity. It's not going to change your outlook. I mean, it's now you have something to be mindful of that you have to work at every single day. And so there is an emotional aspect of it, but it can be managed. So I would say that probably the biggest aspect of dealing with it is really understanding the disease completely. What type do you have? What does it look like? What are the things that are going to significantly change it? And that way you can control those factors. And when you can start to control those factors that play a part in this disease, then I think emotionally your head tends to get wrapped around it a little more quickly. But I'm going to let Dr. Amy talk about the emotional side because she's been instrumental in helping us with not only family caregivers but also our professional caregivers understanding emotions of a number of topics.
Thanks, Mary. And I think it's a great question, and I think there's a few things. It's always a message of hope to me, and realism and hope, and those things are not they're not opposed to each other. They're not mutually exclusive. So the realism is there are some changes that someone's going to have to make. The interesting part, though, to me of this conversation is that if you listen to what's recommended during this webinar about changes, right? It's exercise, it's eating healthy, it's good medical evaluations. Those are things we recommend for healthy people too. We just say they're much more important for people with diabetes. So what we're really saying is, in a lot of ways, people who have diabetes become just more acutely aware of behaving the way that we know benefits all of us. It's certainly not a death sentence. We know that the complications for most people are very manageable by preventing them, and so that making sure that the course of treatment is being monitored and all of that. There is the emotion of, as Mary said, that sense of, oh my gosh. And I think for any of us, when we get any diagnosis of something that's long-term, that there is that feeling of, if you look at what makes people feel old, often what makes people feel old is not their age, it's some shift in their functioning. So to think that there will be a feeling of perhaps feeling old or unhealthy based on this is a normal process to go through. It's kind of going through the grieving process that we know people go through whenever they have something like this happen. But, the outcome of the grief process should be that sense of acceptance. And again, acceptance isn't jumping for joy that you have diabetes. It's the ability to really take that diagnosis and to integrate it into your life and to say, okay, despite this diagnosis, I can live a rich, full life, and perhaps I'm even going to live an even richer, fuller life because I'm going to become much more attentive to my health than I might have if I hadn't gotten this diagnosis. I'm sure all of us know people who've gotten a diagnosis of something and they said it was a gift. And the gift was that it made me aware and it got me doing the things I knew I should have been doing anyway. I mean, I don't know about any of you on the call, but certainly as I go through the dietary shifts and the exercise, I think about myself and I say, okay, so which of these things aren't you doing and what do you need to step up? So people with diabetes get a bigger wake-up call in that. So again, I think it's balancing the realism that, yes, there are going to be some changes and also the hope, about their quality of life and what this will mean in all areas of their life. And then also the hope about different treatments that one of the things as you heard about diabetes, the mortality and the morbidity rates have dropped significantly. That's a really good thing. So we're getting more people diagnosed, but we're also managing it better. So that would be my approach to it.
Okay, next question. I'm working with a client with type 2 diabetes. He's been prescribed a continuous glucose monitor, which is not recognized by Medicare, his primary insurance. Are you aware of any patient-assisted programs to help with the cost?
Mary, you've done some work with American Diabetes.
Yeah, I would definitely check with their local chapter. Sometimes they have some grant funding programs and things. The other thing I would do is check with their local area office on aging or Department of Health and Human Services if they have an aging division. A lot of times you will find grant programs out there, but you know what, you have to kind of be a detective and start searching it out. But I'd first start at your local chapter of the American Diabetes Association and then move on to the area office on aging.
Okay. Well, we are just about out of time for today's web seminar, but I want to thank Dr. Amy Dupree for another great presentation, and thank you, Mary Alexander, for joining us for the Q&A portion. Thanks to you both.
Thank you, Steve.
My pleasure.